Hi, we're Nia and Mary-Anne from NHS Health Coaching. We are metabolic health coaches who are passionate about good metabolic health for everyone. We also love to chat about all things health and to share as much information as we can with people who want to make changes to their lifestyle but aren't quite sure where to start. We're going to release a new episode every Friday where we talk about a different aspect of health. So do subscribe and let us know what you think. We'd also love to know what you're interested in too. So if there's something that you'd like us to have a chat about, do send us a message and we'll do our best to cover it soon. Hello, hello.
Hi, Nia. How are you?
I'm good, thank you. How are you? Well, I'm really good, thank you.
Oh, you're very good. Oh, because what we're going to talk about is something quite interesting, I think, and I've always been quite interested, is about sort of regular medical checks
Yeah.
for well people. And I mean, not everyone who listens to us is part of the NHS, but in the NHS, they introduced what they called NHS Health Checks in
Yeah.
2009. And you and I would both have been practicing at the time. You probably weren't involved too much in
At,
NHS Health Checks.
at that point, we didn't do them, although I
Yeah,
think pharmacists do them now.
do they? Interesting. Well, of course, the medicine business would be lovely to, you know, have
Yeah.
add into that check. But it did exclude everybody with ongoing chronic disease that was already treated.
Yes.
So
Yeah.
it was particularly for well people. And this
Mm-hmm.
is quite interesting, spending a huge amount of money. I can't tell you exactly what the sum is, but it would be meaningless anyway, but a lot of money because
Yeah.
these health checks take 20 to 30 minutes and they involve, personnel, obviously, but they also involve blood tests
Mm.
and a lot of documentation and then follow up as well. So it's a big chunk
Yeah.
of NHS funds. That's the first thing. And this was a new initiative. There were other preventative initiatives in the NHS, obviously like smoking cessation and screening, but this
Mm.
was the really a real big sort of move where the NHS was getting more serious about prevention of chronic disease.
Yeah. Yeah. This was primary prevention, wasn't it? And
Yeah,
that's what we
primary
mean is
prevention.
people who've got
Yeah,
no evidence of established
exactly.
chronic
Yeah.
disease or cardiovascular disease
Yeah,
specifically. But
yeah,
yes, yeah.
yeah. So
Cool.
that was interesting, and I was in practice at the time, and I remember thinking, "Golly, I hope they've piloted this, and that it's actually useful," because we, on the coal face, weren't convinced,
Mm,
and we weren't convinced for some interesting reasons, which the data doesn't particularly bear out, but we thought it would only be the worried well who would come for the health checks, and
yeah.
the people we really wanted wouldn't. And the other thing that it was also designed to address was inequalities in health.
Mm,
And we thought it would never do that. But interestingly, when I've looked at the data, people who live in more deprived areas are actually attending at the same sort of rate
as those
as
in the affluent areas.
yes, which
Interesting.
that surprised me, and I don't like to believe the data, but it's definitely there. So there
Mm,
is some address to health inequality, which is got to be a good thing.
yeah,
So
definitely.
launched in 2009, and they'll tell you how many people and all this, but honestly, it's pretty meaningless.
Yeah.
About 50% or thereabouts of people who are invited take up the invitation. So that's
Mm,
a ballpark figure, and it'll you would get much better bang for your buck if more people did take up the invitation.
yeah, of
If you're
course.
looking at the
Yeah.
data,
Yeah.
so that's one thing. Interestingly, I thought more of those would be women. Why did I
Yes.
think that? See,
Yeah. Interesting.
I'm very prejudiced on it, and actually 54%
Oh,
women.
women. Yeah.
Yeah,
I
so
actually
that
have
surprised me.
yeah. I have an opinion about why people don't often take these up as well,
Do
which
you?
is, well, it's just, I mean, sometimes it's really, really hard to get an appointment that suits your working life.
Okay, so they don't make it easy, you
So they
mean,
don't make it easy.
logistically.
Like
Okay.
you've got to have an appointment, haven't you, with a healthcare practitioner because it's not usually a nurse, it's usually now an advanced healthcare practitioner.
Yes.
They don't work late evenings. They
Yes.
work.
In which case, you're not gonna get
You're
people
not
of
going to get it,
working
yeah, of
no.
people of working age. So
Not
it's
for
not easy.
prevention,
And
someone
not for
might make
prevention
the
because,
time for something,
yeah,
but not for primary prevention.
some people are just not interested in primary prevention or even knowing or just
Or
think, oh,
yeah.
it's not for me. So,
Well, it's
yeah.
like going to the dentist if you haven't got toothache, isn't it? I mean, a lot of people
Yeah.
don't.
So I think a lot of people don't
Yeah.
necessarily think, I'll go and find out what this is about. They
Well, I
just,
don't want to know what's wrong anyway, but also I'm very healthy and I'm young. So interestingly, the age 40 to 74 every
mm,
5 years, that was also interesting to me why they
mm.
started it at 40, which seems
Oh, it's
fairly
downhill from
young to
there.
yeah.
Downhill from there.
That is such rubbish. Um, but yeah, I thought 40 was quite young to start it actually. If you're looking at cost effective
Mm,
um
mm.
what you're getting out of it.
But then also, I think now, although that in 2009 you might have thought 40 was quite young, now that I'm seeing more diabetics, like more type
Okay.
2
Oh
diabetics in
yeah.
their 20s, I don't think that
Okay.
40 is too young.
Okay, that's interesting.
Mm,
We'll talk a bit more, and I really want to ask you because you've just had a health check, which is
I
really
have.
cool, and you are young. And I just want to ask you some really, detailed. What did it entail? What did you feel about it? What have you got back from it? What did
Mm,
you expect? So, and then we'll go back to some of the
things that we
problems
do with
I've
it.
seen with the data. So tell us about your health check. Did you want to be invited?
Well, to be honest, I didn't know I was gonna be invited
Okay.
because I knew about them and I knew
Mm,
that you usually got offered when you were 40,
yeah.
and I didn't get offered when I was 40. I mean, to be fair, I got the invitation a week after my 41st birthday.
Okay. Okay. So
I
they
don't know,
they're a little bit behind.
but then
Yeah.
I actually thought that these had stopped due to the pandemic. So in COVID times, they
Yes,
did
they
take a
did
break,
stop for a while, didn't they? Yeah.
and I wasn't sure that they had restarted, and I
Okay.
wasn't sure that my practice was even offering them. So
Yeah.
I got
Yeah.
the
Yeah. Yeah.
message, and you know what I'm like. Any
Yeah.
opportunity to go and find stuff out, I thought
Yeah.
would be
Yeah.
interesting.
So you did like a little mission on a sample of what it's like to have a health check.
Yeah, well, I thought it would be good
You
to go
weren't
and find
worried
out. I
particularly.
wasn't worried at all.
No. Okay.
I just wanted to know what my
Yeah.
I actually quite fancied finding out what my figures were.
Yeah.
No one was like, so yes, I booked the appointment very easily. Went in 8:10 in the morning, very early.
Golly.
But yeah, 20 it was about half an hour. Most of that time was just spent chatting, to be honest, with the healthcare
Okay. So
practitioner.
that's a lot of time in general practice.
It is a lot of time in general
I mean,
practice.
you
You
could
don't
have
normally get
seen
that
a
amount of time.
few,
I'd have
patients
had
in that
3
time.
GP consultations in that
Yeah,
time.
exactly. I mean, it does make you think this is a very expensive venture.
Yeah, so
Okay.
saw her. First of all, they take your blood pressure,
Yeah.
then they weigh you, they measure your height, they do your waist circumference.
Okay.
She took some blood from me for cholesterol and for diabetes testing.
And everyone gets that. That's like
Everyone gets this
baseline
is the
T. Yeah.
standard, yeah.
Okay.
And they talk to you about your lifestyle. So they ask you how much exercise you do,
Yes.
they ask you how much alcohol you drink,
Yeah.
if you smoke, if you I mean, I can tell you, I'm just going back into my records to just see what else they
So
recorded
the
about
the
me. Oh,
lifestyle stuff, diet. They ask you about diet.
they ask you about your diet. And I mean, that was interesting because the healthcare professional who I was talking to at the
Yeah.
beginning of the consultation asked me what I do for a living.
Oh yeah. So you
Ultimately,
said, "Oh, I'm a picture framer." Yeah. Uh,
I should have said that. I should
yeah.
have said, "Or a picture
You
frame."
should.
But I always think about that
Yeah.
afterwards. Interesting. These are some of the really weird and interesting questions that they ask. And actually, I know that this is part of the questionnaire because I see
Okay.
this on my pre-diabetic referrals. So asking about physical exercise, but
Yes.
specifically asking, how many hours in the last week have you spent cycling? Interesting, I think.
Golly, what if you don't? Yeah. Naught.
How many hours in the last week have you spent walking? For
Yes.
me, that's a lot anyway, so that's fine.
Yes.
And how many hours in the last week have you spent on housework or childcare? Because obviously that's demanding physical work and we have
Yes.
to be aware of
Okay. So
that.
they're trying to take everything incidental exercise
Yeah.
into account.
Also about gardening and DIY. They want to know what you do in terms of, are you sedentary at work or do you have a manual job,
Okay.
physical job?
Okay.
And then they want to know how fast you walk. So those are the
How
things that
fast do you
yeah.
walk? So how do they measure that?
Well, they just ask you, how fast do you walk? Now,
You mean brisk,
are you a brisk
moderate,
walker or are you a slow walker? Yeah, I
okay.
mean, for me,
So
I know that I'm a
it's what
brisk
you
walker.
say. Yeah,
It's all
okay.
yeah, it's all dependent on what you say. I mean, I
Yeah.
actually have the evidence to prove I'm a brisk walker as well, but that's different because it's
Yeah.
just because of what I do. And then they also take your pulse to make sure you're not in AF.
Yes.
Because obviously it's a good opportunity, isn't it, to
Yeah.
identify whether somebody's got atrial fibrillation or an
Yes,
irregular
yes.
pulse. Yeah, so that's all they ask. But then they put that information into something called a Q risk
Right.
assessment, and
Okay.
that's where it becomes a little bit more interesting.
Yes. I mean, I think the activity, I remember this well, but it's all coming back now. This activity business is very hard to measure in
It's
any sort of,
incredibly hard to measure.
you know, in any sort of constructive way.
Yeah, I mean, I've got the advantage, haven't I? Because I'm literally sitting on the other side of these health assessments,
Yes.
advising people what they need to do.
Yeah, no, of
Um,
course. I
so
mean, and
I
you know,
know,
asking your clients, and
yeah,
I mean, a lot of my patients used to say they walked miles or whatever, but I mean, they were walking a dog that sniffed a lot, and
yeah,
I
yeah.
I saw them walking their dog and thought,
You're not
I don't
walking
think that's
briskly.
increasing your pulse rate at all. So it's
No.
all, I'm not saying it's not a good thing to walk your dog, but
It's all in the way that you ask the
yes,
questions
yeah.
and how, because you can say, "Do you walk a lot?" And someone can say, "Yes, I do." But if they
Yes,
just
yeah,
amble down the road, they're not walking to any benefit to their health. Is it
yeah.
walking that you are out of breath and that you could hold a conversation with someone but you
Mm,
can't sing? That's
mm.
what you're wanting to
Yeah, more
ask.
specific. So they're
Yeah.
not terribly specific.
No. I mean, I think
Okay.
it would just depend on the person that you've got.
And things like alcohol, they are quite specific. Smoking, they are quite
Yes. So with
specific.
alcohol, they're asking you the
Yeah,
Audit
how
C
many
questions.
units?
So,
Yeah.
how frequently do you drink alcohol? How many units do you drink on a typical day? How frequently do you drink 6 units or of alcohol or more, or 8 for a man? So, those kind of things are a
What, in
bit more
one go?
specific. Yeah, in one go. So,
Okay.
they're looking for sort of binge drinking.
That's interesting. Okay. And then they send off your blood.
Yeah. And then lickety split the next working day because that's super quick. You
Golly,
get your
that's good.
results back.
Right.
And the
That's good.
advantage now is that, of course, we get these in the NHS app, so you can see them
Yes.
super quick.
Yeah. And the Q risk, tell me more about the Q risk.
So, and this is where it becomes interesting for me. So, Q Risk is a tool that is
Yeah.
used in general practice.
Yeah.
And there have been a few iterations of Q Risk along the way. And in 2009, we were using something called Q Risk 2, and we're now
Yes.
using something called Q Risk 3, and there are differences.
Yes.
But
So
what
it's more sophisticated. They've got
is a
more
more
sophisticated.
sophisticated
There
tool?
was one originally.
Yeah,
Q risk
of
one. Yeah.
course, yeah. So what it's based on is real data, UK specific data
Okay.
collected from GP practices over a number of years all over the UK. So
Okay.
what you are comparing yourself to is an average person in the UK who is
Right.
the same sex, ethnicity, and
Yeah.
age to you.
Okay.
And what it's then using is a really sophisticated algorithm to work out your relative risk of a cardiovascular event over the next 10 years.
Interesting. Okay. And in your research about Q risks, were you impressed?
I was actually, yeah, it's quite an
Okay.
interesting thing. So,
Yeah.
so the data is basically a big research product that your
Yes.
GP practice opts into.
Yes.
So big
Yes.
sample sizes, just under 8 million people's data has been
Yes.
used. So
Interesting.
lots, and people between 25 and 84, and
Okay.
it's based upon all of the people who are using this data are all free of known cardiovascular disease and not treated in any way with a
Okay.
statin at baseline. So all of these people are
Yeah.
untreated,
Yeah.
not knowing their risks, so they are, sort of the baseline
Yeah.
is a good comparison. So they're not,
Yeah.
any way sort of biased. So and as I said, it's used for the risk of developing a heart attack or stroke over the next 10 years. It covers a wide variety of bases. So it uses your ethnicity
Yeah.
because depending on where
The
you come from,
differences.
there are
Yeah.
differences in your risk factors. Deprivation, so depending on
Okay.
the a bit where you live in the UK, that will affect your health outcomes. We know that.
Okay.
Your systolic blood pressure, which is the top number. So if you're looking at someone who's 120 over 80, we're looking at the 120 part. And
That's
that's the
interesting.
bit
So
where you
they don't use a diastolic.
don't use diastolic, they only use systolic, which is the
Okay.
part of the blood pressure which measures when your heart is actively doing something.
Yeah. So the top pressure.
Yeah.
Yeah.
They use your BMI, point
Yeah.
of contention for me, but we'll
Yes,
talk about
very
that in a minute.
contentious, of course.
They use the ratio of your total cholesterol to your HDL cholesterol, which is your high density
Right.
lipoprotein, the good stuff.
Yeah. Another contentious matter. Yeah.
Indeed. Your smoking history, your family history of coronary heart disease in a first degree relative under
Okay.
60, and whether or not you have type 1 or type 2 diabetes.
Yeah.
It also includes a known diagnosis of hypertension and then some inflammatory diseases like rheumatoid arthritis.
Right.
If you've got AF, atrial fibrillation, which is where your heart beats out of rhythm, or if you've got stage 4 or 5 chronic kidney disease. So that was in
Okay.
the original Q
Yeah.
risk 2.
Right.
And then they updated that to include all of that, but also to say actually it would be more effective if we could also look at people who've got chronic kidney disease stage 3 and above, because actually we know that even early chronic kidney disease can increase your vascular risk, your cardiovascular risk.
Okay.
It also took into account something called systolic blood pressure variability. So
Right.
this is really interesting because some people are known as having what's called a labile blood pressure,
Yes. Yes.
which means that your blood pressure isn't constantly in the normal range, but it's not constantly in the high range
Okay.
either.
Yeah.
It sort of varies quite a lot. So what they do is they use a standard deviation between 2 or 3 measurements of your blood pressure
Right.
to
Right.
see how variable your blood pressure is. And then
That's
they
interesting.
interestingly, they have now then added in some really important, I think, extra things to be aware of. So your history of migraine, because of course, if you suffer from migraines, some are vascular in nature, that increases your risk. History of corticosteroid use. We
Yep.
know that the way that steroids work means that you eat more and put on more weight,
Yes.
increases your risk of obviously metabolic disease like type 2 diabetes, which therefore impacts your cardiovascular risk. See, it's all kind of interwoven here.
Yeah. Yeah.
All inflammatory conditions because of the nature of inflammation and
Yeah.
its risk on inflammation of the arteries. My favourite, which I think is really important to note, which is atypical antipsychotics. Because
Yes.
we know that some of these medications that
Mm-hmm.
we use to treat people with schizophrenia, bipolar
Yes.
disorder lead to huge amounts of weight gain and metabolic
Yes.
syndromes like type 2
Yes.
diabetes. Those who have severe mental illness and erectile dysfunction, interestingly enough, because
To
obviously if
do
you've
with the
got
vascular.
a
Yeah.
vascular issue that means you
Yeah.
can't have an erection, that's likely to
There'll
mean
be
you've got
other
other stuff,
vascular.
vascular
Yeah.
issues.
Yeah. Yeah.
Yeah.
Yeah. Get that.
So, in a way, that's a
So this is
massive
the most
development
sophisticated version.
that we've got at the moment. Yeah,
Yeah.
absolutely.
And does everybody get that one?
I think everybody gets that one and it's built
Okay.
into the GP systems. So, what happens is after your health check, when the results come back, the healthcare professional goes back into your records and fills
Yes.
out this form with the information that you've got. So, for example, they could fill in half of it with what they had from me yesterday,
Yes.
but they couldn't, until they got my blood results, they couldn't actually say,
Yeah.
well, she's not a diabetic or she's not got
Yeah. Yeah.
a cholesterol problem. So, that's all interesting. But very interesting, there are some things that I think are missing.
Yes.
And so, as I said, bone of contention is that it goes on BMI and not
Yeah.
on
Which we
waist
know is not
circumference.
a very good measure.
So, interestingly enough, my BMI is perfectly healthy and fine.
Yeah.
But if I had, I suppose, if I had a higher BMI, yet my waist circumference was what it is currently,
Yes. Yeah.
then it would look like I was overweight and it might skew the results a bit.
So the results get skewed pretty easily.
So
That's what you're
there's
saying.
an
Yeah.
opportunity for results to be skewed. So
Yeah.
by not having the waist circumference, which we know is the important thing, because where you're carrying your
Yeah.
visceral fat around your abdomen has a link to whether or not you develop type 2
So I
diabetes.
think there's a move to take BMIs out. I don't mean on health checks, but in
No,
general,
in
I
general, to
think
look
there's
at,
quite a
yeah.
big move because it doesn't measure visceral fat, basically.
Yeah. And imagine if you were a different ethnicity. So we
Yeah,
know that South Asians, particularly, can have a
yeah,
normal, healthy BMI,
yeah.
but they
More
can
visceral
have
fat.
more visceral fat and a
Yeah,
higher waist circumference, which
yeah,
would mean that there are increased risk of cardiovascular disease, but that would be missed by this
yeah.
particular tool. So that's important to note.
And somebody with enormous muscle mass, for instance, would
Yeah,
be the other way. They
exactly.
would look like they had more visceral fat than they did.
Yeah.
Yeah. Okay.
So, and then I also found out, because, I like to
Yeah.
find these things out,
Yeah.
that they actually did an independent evaluation of Q Risk 3 in 2023.
Yeah.
And this heart journal found that we overestimate in older populations by as much as 20% their
Okay.
cardiovascular risk.
So they're not taking age into account.
So it doesn't look like it's being as accurate when you're older, which could lead to
To
over-treating.
over-treatment. Okay.
And on the converse
I
side,
absolutely believe that,
yeah,
yeah. So the person operating that Q risk has to
has to
use
use it
some
wisely.
nows.
Yeah. And the other thing is that it seems to be more accurate for females than males. Who knew? Interesting.
Okay. Okay.
So I think it's one of those things that is really important because it's a helpful tool. And for people like me who have gone in um,
Yeah.
and have looked at their results, I calculated my own Q risk 3 score
Yeah.
because I'm a geek,
Yeah.
and I wanted to know what it was.
Yeah. Yeah.
But it's helpful, but it doesn't replace the expertise of the clinician on the other side of the screen, and it's
Yeah.
a good conversation for patients. But it's also interesting that because it's only looking at your cardiovascular risk over the next 10 years,
Yes.
it could underperceive your risk if you were younger,
And
um,
over-perceive it if
overperceive
you
if
were
you're
older.
older. And it also doesn't include something really important, which is the length of time that if you were diabetic, type 2 diabetic, that you'd
Yeah.
had it. So
Okay.
somebody who
Yeah.
develops type 2 diabetes in their 40s, for example,
Yes, their risks
will
will
have a totally
be
different risk to
yeah,
someone who's developed it at
and
75.
they're getting the same score on their
Yeah,
Q risk.
yeah.
Oh, well, these are the sort of I mean, this is the problem, isn't
See,
it,
there's
with
no real
standardized
magic bullet.
no.
Yeah.
So the other thing that's slightly contentious is that they're using total cholesterol and LDL, aren't they, the
HDL,
ratio?
HDL to
HDL,
total cholesterol ratio. They're not including triglycerides. They're
which
not including
which we
LDLs.
know that the triglyceride HDL ratio, is it HDL? Is
Is the one
a
that's
good marker of metabolic disease,
yeah.
yes,
So this
or
is
metabolic risk. Okay.
so this is what you get out of your health check basically. And then what they do is when you get these figures, they present this in a patient friendly way. So your results are presented as the risk of a heart
Yeah,
attack in the next 10 years is X amount or X
yeah,
percent.
yeah,
Okay. And that means that 100 people with the same risk factors as
yes,
you, out of those 100 people,
yeah,
this many will have
yeah.
a heart
So
attack in the next 10
so
years.
maybe, I don't know, 10 out of 100 or whatever it is
Yeah.
with the same
Yeah.
yeah. And how so that's one of the things when I looked at the data and they looked at, how clever is this? How
Mm.
constructive is this? What are we getting for our money?
Mm.
There were lots of good things,
Yeah.
but one of the things was that how do you communicate the results in a way that's really constructive
Yeah.
for the person on the other end? And I
So
think, I mean, we're a particularly, well-informed
population.
audience,
Yeah.
yes, but not everybody is.
No. So I had a look at what else it says, and this is where I think it's interesting. So
Mm,
you get your 10-year risk. So you can say,
yeah,
so your risk is like 0.5%, which means that 1 in 100 people like you
yeah,
would have a heart attack in the next 10
yeah,
years. And then it gives you the score of a healthy person who's the same age, sex, and ethnicity of you. So you can compare yourself with
okay.
someone of a same age, sex, and ethnicity. So that's where your competitive streaks
So
comes
you'd be
in.
better than most people if
So
you
so
looked at
when I
your
compared
results.
my results, I was
Yeah,
better than
yeah,
somebody of the same age,
yeah,
sex, and ethnicity as me.
yeah,
And then it gives you your relative risk, which is the most important thing. So it's your risk divided by the healthy person's risk.
okay.
And that's a little bit less than the overall 10-year risk. And then it gives you, I think lots of people who've got like smart scales and want to know like
Yeah,
their metabolic age and things like that, it gives you your healthy heart age, which is the age at which a healthy person of your sex and ethnicity has this Q risk score. And obviously what you
mm,
want is for that age, your Q risk 3 healthy heart age to be lower than your actual biological age. And mine
yeah.
was lower. And so I'm very
Of
happy.
course it was. Of course it was.
Well, I was worried, that,
Well,
I
you like
text
to worry.
I
You
like to
like to
worry. I text
worry.
you and said,
Yeah, I
"Oh,
could
what
have
if I'm
told you.
pre-diabetic and I've got
I
high
could have told
cholesterol?"
you that yours would be good because really you live incredibly well
But you
and
never know,
you
do
have a
you, in
great
case.
lifestyle. No. I'm still slightly cynical about the communication and the sort of
So
how much it means to
yeah.
somebody.
So I think it really has to be this. So I don't
How
have the
individually is it tailored
yeah, I don't
by
know.
that
So
person?
This is the
Yeah.
interesting thing as yet. So I only had my check yesterday. I've had
Yes.
my results through the NHS app. My
Yeah.
doctor has just tagged all my results as normal because they are.
Yeah. Okay.
And I haven't had anything yet back from the surgery to say this is what's going to
Yeah.
happen.
So will you get anything back, I
Well, I
wonder?
think so because the healthcare
Yeah.
assistant who I spoke to said, when I get your results back, if the doctor gets there first, they might ring you if there's anything concerning. So,
Which they won't.
which,
Yes.
well, if I mean, they won't now.
No, they won't.
Or I'll just do your Q risk and I'll let you know if there's anything to worry about. And I think it's all in the communication to the
Mm,
patient after the event. So,
I agree. Because, how constructive is it then for that individual? So,
yeah,
you really are sort of not a great example, but if
no,
somebody had a borderline, say your risk was 13%.
yeah,
I can't remember what the cutoff is. There's a cutoff, isn't there, where you literally it triggers statin prescriptions, and
yes,
so
yeah.
that what I mean is there's got to be some art in here.
Yes, I've just found out actually, I thought I'd look it up just to double
Mm,
check at the end. So 10% risk level
yes,
um is the cutoff. So below 10%,
you don't
you don't
trigger
you're low
anything.
risk, they're not worried about you.
Okay,
Between 10 to 20%, they are recommending you make lifestyle changes to reduce your risk and consider statins.
okay,
And high risk 20% or more will be more likely to benefit from statin medication in addition to making lifestyle changes. And it
yeah,
says
okay,
the decision on whether to take a statin will depend on your personal attitude to risk and taking medication. True.
yeah,
It is
fair enough.
important to remember that taking a statin is not a substitute for making lifestyle changes. The latter will
Yes, there's
always
also
bring the
that.
highest benefits to your health. And
So there's
that's totally
also
true.
that. I think the argument is if you found somebody with diabetes, it's a cost effective test, isn't it?
Oh, I think yes, absolutely. But then I think the other benefit of just saying to people that you've got the option to be referred to one of these programs to improve your health is
Yeah,
that most people don't know how to be healthy in a way that
yeah,
we would recognize as healthy.
yeah,
They think they are because it's a different
yeah,
kind of thing. But actually, I think there are benefits to just at any time of life
yeah,
having a 360-degree
yeah,
analysis with someone who's got the time to do that with you.
yeah, interesting.
So,
Like
yeah,
health coaches.
like health coaches, obviously. Yeah.
Yeah, and also I always think looking at the data today and how expensive this is, wouldn't it be great if surgeries ran sort of groups
For these people.
around prevention and health?
Well, so what has happened is, and this is true of the thing that I do, is that there are some services that have been developed to either run group work with these
Yeah,
people who've been identified through their health check
yeah,
as pre-diabetic,
yeah,
or through a digital face-to-face coaching, which is what I do.
yeah,
I don't do
yeah.
the group stuff,
Which is also expensive, of course.
which is also expensive. But in order to kind of
Yeah.
reach these people, and I think, I'm biased because I coach on the digital one-to-one, but I think that's so much better
Of
resource.
course, I can imagine that it's much better for the patient because you're much more, or the client, much more tailored to
So
that
much more convenient for
individual.
them, easy to kind of hop onto a
But can we
computer.
afford to do this, and is it cost effective?
I think that's a really big question, and I just
Mm,
don't know.
I
But I would
can't.
say that
Yeah.
if we're still doing this nearly 20 years later,
Do you
there must
think
be
they've
some
worked it out?
benefit.
It's cost effective.
I don't
I
know
know,
with the
I
NHS, I
have,
really don't know.
to be honest, I have very little faith in statisticians.
You can make the data say whatever you want if you
Yes,
manipulate it
exactly.
in the right
But
way.
no, what is really fascinating, and I'd like to explore it more, and we'll do that, is, how we sort of individualize this and how we make it work for us with limited resources.
Mm.
We have a nation of unhealthy people. That's a fact.
Yeah.
And so, how do we make our limited resources give us the best return, not only for the individual, which is obviously part of it, but also as a nation? How do we make that tax work well?
Yeah.
And prevention on paper is got to be the way to go.
I think,
But it's a bit like screening, if you ever looked at screening.
yeah, I mean,
There's
for the
some
amount of money
very
that it costs to screen, are they actually,
could you treat better? I mean, could you
yeah.
just put the money into treatment? And I mean, that's the sort of interesting
Yeah,
arguments.
yeah, yeah, yeah. Well, there's always going to be the argument for screening is there's always going to be one person
Yeah.
picked up that you would never have picked up before
Yeah,
because they've
sure.
got, very unusual symptoms that they would never have had checked out if it hadn't been for screening.
Yeah.
I think they're always going to be worth the money. There's no way you can say they're not because even if you just picked up
No,
one
exactly, and to
cancer,
the individual, it's not you can't really
of
apply
course,
it.
of course.
It's more if you were, above this and looking
Yeah,
down,
yeah.
would you say that screening, I don't know, breast cancers for screening for breast cancer, so that the mammography service, what are you
Is
getting
worth
back
it.
for
Yeah,
your because it's very
yeah.
expensive.
So when I kind of thought back on this whole process, and the reasons why I said yes,
Yeah.
I mean, predominantly the reasons that I said yes to this health check was so that I could talk about it with you.
Yeah, yeah. And also that you should put your money where your mouth is,
Well, I
really. I
should.
mean,
Yeah, absolutely. I
you're
should
all
know what my
about
figures are.
prevention.
Yeah.
Yeah.
And to a certain extent, now I've had my results back, I feel like my hard work has been worth it and that actually
Okay.
everything that I am doing
Yeah.
is
You're on the right track.
it remotivates me to continue because I know
Yeah.
that I've got empirical evidence now that this is good for my health, that
You
everything that I
could
am
you could
doing is good.
also argue that if you got really good results back, that you then
Go
take
mad.
the foot off the
Yes.
the foot off the
Well,
juice and say, "You know what, I'm very healthy, so I can do what I like."
yeah,
I
you
mean,
could
there's
do
always
that.
that argument.
There is always that argument.
Mm.
And I think maybe that's just not the way my brain works.
No, I get that.
Right. Because, this is
Yeah, no,
like,
I
I've
get
done
that.
well, I'll strive to be
I
better.
don't know. I mean, I'm different and I'm in a completely different age bracket to you. And I'm very cynical about algorithms and percentage risks where there are factors that are not gone in there because there's still a lot of people that have to be treated
Get what you,
to save
yeah.
that one.
A number needed to treat, yes.
All that
And that,
the number needed to treat always blows my mind.
yes. And for a certain extent, you're never going to get a good number needed to treat for chronic disease, for lifestyle
No.
diseases. You are for bacterial infections and
Yes.
things like
Yes.
that, because of course they only respond. It's a pathogen. You treat the pathogen, you
Exactly. You
you are
have to have the
done.
pathogen to get the
Yeah.
response to get yeah.
A lifestyle disease is so much more complicated, and that's why you and I
Yeah.
find it so fascinating. Let's be honest. It's not just,
And
oh,
we
it's a
all
bug, let's
know
zap it.
that there are people who do really well in life and have quite enormous risk factors.
Yes,
So
of course. And
there's
there's
a lot of
always someone who'll buck
th-
the trend. There's always a
there's all
smoker who'll
yeah.
live to 100 and
Yeah,
never
yeah,
get
yeah.
COPD. There is always
And also
something.
into that algorithm that you put in particularly Q risk in, which I've always found quite hard to get my head around, is you haven't put connections to other people. You haven't put relationships, families, support,
Yeah.
housing,
No.
environment.
See, the deprivation score is purely done on your postcode,
Well,
but
yeah, that's not really fine tuned. I mean,
it's not as in detail as we'd like it to be.
yeah,
The family history information is only
yes.
based on first degree relatives, not on anything
And
else.
even then, if first degree relatives, there's some, you could have had a father who died of a heart attack at 82.
Mm,
I
mm,
mean,
mm.
I presume that it is age related, but you know what I mean. People have to die of something, so that doesn't
Yeah.
necessarily constitute a risk.
Oh, I've
Anyway,
just.
little problem of just triggering the medication, a bit like GLP-1s,
Mhm.
and not doing the lifestyle. So that's another contentious bit of
But this
this.
is the thing that we've talked about time and
Yeah,
time again. This is an
yeah,
NHS website. This is from a GP practice,
yeah,
not mine. I'd like to
yeah,
put out there. But interesting, it says, I love the fact that they say you're going to have much more benefits from lifestyle changes than anything else because they're
yeah.
saying that will bring you the
It's
highest
true.
benefits to your health.
Yeah,
Totally true.
yeah.
But we're still not telling people what those are.
Because we often don't know ourselves. Yes.
And that's where you and I always felt that
Yeah.
we
You
paid lip
people need
service to
much
it.
more specific.
Yeah.
So what's a good diet? I mean, how do
Yeah,
you
exactly.
what is enough exercise for you?
Exactly. Yeah.
Yeah.
So but
And
yeah,
stress, do we
and
ever
stress and
measured
how well you
stress?
sleep. But
Yeah.
actually
Sleep.
yeah. So fascinating experience to go through. Interesting now because I'll probably go back in
Yeah,
5 years and it'll be like my little MOT.
yeah,
And I
yeah.
think
Well,
that's,
yeah,
you know,
and over time you'll be able to plot that trend for yourself.
and I
But
do
I think
think,
with age, unfortunately, things wear out a bit.
well,
So
they
I mean,
do.
I'm in my 70s, and my risks are higher than yours. I mean,
Of
of
course they are,
course they are.
because and we do know that people in general, their blood sugars run a bit higher when they're
Yes, their
older,
blood
all the rest
pressures
of it.
run a bit
Yeah,
higher, their kidney function drops
will
off. All
decline,
of that's pretty normal.
which it is. So it all has to be taken with the benefit of hindsight and
Yes.
looking back at all these
Okay, which is
things.
why I'm sort of slightly cynical
Skeptical.
about the numbers on the queue list, because I think it's very standardized, and they don't take into account quite a lot of things. Anyway, that's
yeah, I
me,
think
cynical as ever.
I think it's all about the communication that you get from the doctor at
Yes,
the end.
exactly, and how good that is, and how motivating and inspiring it is to make good changes rather
That
than
make a
frighten
difference.
anybody, make them anxious, tell them they need to take a drug for the rest of their life without really, motivating them about lifestyle. I think you'd be much better off with motivation. Anyway, that's me.
Yes, but some people would rather pop a pill, wouldn't they? Because they haven't got time to
Well,
address their
so
lifestyle
they
changes.
well, so they think, but they're ill-informed.
Of
Not
course
to
they are.
say that
You know that.
statins, by the way, aren't a useful drug in prevention. I wouldn't say that it isn't, but you do have to communicate well. Okay, that's cool. Thanks for that. Bye for now.